Testicular germ cell tumor, TGCT, originates from the germ cells that normally develop into sperm. Clinically, it presents as a painless, firm nodule within the testis and can be detected by self-examination or physical exam. Early recognition of this lump is crucial because treatment outcomes are excellent when the disease is caught at a localized stage. Germ cell tumors arise from embryonic precursors that fail to differentiate properly. They are broadly divided into seminomas, which retain features of early germ cells and grow slowly, and non-seminomatous germ cell tumors, NSGCT, that contain more primitive or differentiated components such as embryonal carcinoma, yolk sac tumor, choriocarcinoma, and teratoma. This classification guides both prognosis and therapeutic choices. TGCT is the most frequent malignancy in men aged 15 to 35, accounting for roughly 1% of all male cancers. Because it is highly curable, especially when diagnosed while confined to the testis, awareness and prompt evaluation of any scrotal abnormality are vital for maintaining the excellent survival statistics seen in modern oncology. Rare inherited variations in genes such as KITLG, DMRT1, and others increase the susceptibility to TGCT by altering germ cell development pathways. Men carrying these variants have a several-fold higher lifetime risk, analogous to inheriting a family recipe that makes the testicular environment more prone to malignant transformation. Failure of testicular descent before birth leaves the gonad in a warmer intra-abdominal environment, which disrupts normal germ cell maturation and raises the odds of TGCT by up to tenfold. Early orchiopsy, ideally before age 2, mitigates this risk by repositioning the testis into the cooler scrotal compartment. Having a first-degree relative father, brother, or son with TGCT roughly doubles an individual's risk, indicating a heritable component beyond common environmental exposures. This familial pattern justifies targeted counseling and more vigilant self-examination in affected families. Exposure to chemicals that mimic estrogen or interfere with androgen signaling, such as certain organochlorine pesticides, bisphenol A, or phthalates, has been linked to modestly increased TGCT risk. These agents can perturb fetal testicular development, creating a subtle predisposition that manifests later in life. Survivors of a primary TGCT have a heightened chance of developing a contralateral tumor, especially within the first decade after treatment. This is thought to reflect a field defect in the remaining testis, underscoring the need for lifelong surveillance of the opposite side. Normal spermatogenesis follows a tightly regulated sequence of mitotic proliferation, meiosis, and differentiation. Disruption of DNA repair, epigenetic control, or signaling pathways can cause germ cells to escape normal checkpoints, leading to uncontrolled proliferation and the emergence of a tumor. Key oncogenic drivers in TGCT include activating mutations in KIT and KRAS, loss of function alterations in TP53, and the characteristic isochromosome 12p, I12p amplification. Together, these alterations act like accelerator pedals, promoting cell survival, proliferation, and resistance to apoptosis. Seminomas consist of sheets of identical clear cytoplasm cells that resemble primordial germ cells and usually spread laterally. Non-seminomatous tumors display heterogeneous components: embryonal carcinoma, yolk sac tumor, choriocarcinoma, or teratoma, each with distinct growth rates and metastatic potentials, requiring more aggressive therapy. TGCT generally follows a predictable lymphatic route, first to the para-aortic retroperitoneal nodes, then to distant sites such as the lungs, liver, and central nervous system. Understanding this pattern helps clinicians choose imaging fields and anticipate symptom location. Approximately 1 per 100,000 males per year develop TGCT globally, making it a rare but clinically impactful disease. The incidence varies markedly by region, reflecting differences in genetics, lifestyle, and diagnostic practices. TGCT shows a bimodal age distribution. The primary peak occurs between ages 15 to 35, aligning with peak spermatogenic activity. A secondary smaller peak after age 60 pertains mainly to certain non-seminomatous histologies. Highest TGCT rates are reported in Caucasian populations of Europe and North America, whereas rates are lower in Asian, African, and Hispanic groups. These patterns suggest interactions between genetic susceptibility and environmental exposures. Over the past 3 to 4 decades, TGCT incidence has risen modestly in most high-income countries, likely due to improved detection, earlier diagnosis, and perhaps shifts in environmental risk factors such as endocrine disruptors. The most common presenting feature is a painless, firm enlargement of one testis. Pain may appear if the tumor hemorrhages, invades surrounding tissue, or causes acute torsion, prompting urgent medical attention. Some TGCTs secrete beta-HCG or other hormones, leading to endocrine effects such as gynecomastia, decreased libido, or altered body hair distribution. These perineoplastic signs can precede the detection of a testicular mass. When disease spreads to retroperitoneal nodes, patients may develop dull back or flank pain. Pulmonary metastases cause cough, dyspnea, or hemoptysis. Brain involvement can trigger headaches and neurologic deficits. Rarely, TGCT releases cytokines or other bioactive substances that cause systemic fever, unexplained weight loss, or hypercoagulability. These manifestations often improve after tumor removal, confirming their perineoplastic nature. Physical examination remains the first step. The clinician inspects for asymmetry, palpates for firmness, and assesses for tenderness or hydrocele. A careful exam can differentiate a solid tumor from benign entities like epididymal cysts. Scrotal ultrasound is the primary imaging modality, distinguishing solid from cystic lesions and providing size measurements. Cross-sectional imaging, CT, MRI, PET, is reserved for staging to evaluate nodal involvement and distant metastases. Serum markers assist in diagnosis, risk stratification, and monitoring. Elevated FP is specific for non-seminomatous tumors, while beta-HCG can be raised in both seminoma and NSGCT. LDH reflects tumor burden but is less specific. Definitive diagnosis requires pathological evaluation of the removed testis. The pathologist assesses tumor type, proportion of components, vascular or lymphatic invasion, and surgical margins, all of which influence staging and treatment planning. Staging integrates tumor size T, nodal involvement N, and distant metastasis M per the JCCT-NM system. The International Germ Cell Cancer Collaborative Group, IGCCCG, further categorizes patients into good, intermediate, or poor prognosis based on histology, marker levels, and disease extent. Classic seminoma consists of sheets of bland, clear cytoplasm cells that are highly radiosensitive and have an excellent cure rate. It typically presents in the 30 to 40 age group and seldom produces serum markers. Spermatocytic seminoma occurs in older men, often after age 50, and grows very slowly. Unlike classic seminoma, it rarely metastasizes and is usually managed with orchiectomy alone. Embryonal carcinoma is a high-grade NSGCT that displays primitive, poorly differentiated cells. It frequently secretes beta-HCG, invades locally, and requires multimodal therapy, typically surgery followed by cisplatin-based chemotherapy. Yolk sac tumor, endodermal sinus tumor, produces high levels of FP, and is the most common TGCT in infants, though it also appears in adult NSGCTs. It can be aggressive, demanding systemic chemotherapy after surgical removal. Choriocarcinoma mimics placental tissue, secretes massive beta-HCG, and spreads hematogenously early, often to lungs and brain. Because of its rapid dissemination, intensive multi-agent chemotherapy is the cornerstone of treatment. Teratoma contains differentiated tissue from multiple germ layers, such as hair, teeth, or cartilage. In adults, it behaves as a malignant NSGCT component and often requires surgical excision. In children, it may be benign. Mixed germ cell tumors combine two or more histologic types, for example, seminoma plus embryonal carcinoma. Treatment is directed toward the most aggressive component, typically using combination chemotherapy and surgery. Stage 1 denotes disease confined to the testis. Stage 2 involves retroperitoneal nodal spread. Stage 3 indicates distant metastasis lung, liver, brain. Stage 4 reflects widespread uncontrolled disease. Staging directly informs therapeutic intensity and prognosis. Radical inguinal orchiectomy removes the affected testis and spermatic cord through a high groin incision, preventing tumor seeding into the scrotal skin or local lymphatics. It provides both therapeutic removal and tissue for definitive histology. For low-risk stage 1 patients, active surveillance, regular physical exams, serum markers, and imaging offers a way to avoid overtreatment while promptly detecting relapse. Compliance with the schedule is essential for maintaining cure rates. Seminomas are highly radiosensitive. A modest dose, 20 to 30 gray, to the para-aortic and pelvic nodes eradicates microscopic disease in most patients, achieving cure rates above 95% with limited long-term toxicity when carefully planned. BEP, bleomycin, etoposide, cisplatin, is the standard first-line regimen for most NSGCTs, delivering high cure rates. EP, etoposide plus cisplatin, is used when bleomycin is contraindicated, while VIP, etoposide plus ifosfamide plus cisplatin, offers an alternative for refractory disease. RPLND surgically removes bulky retroperitoneal nodes, chiefly in stage 2 non-seminoma or when residual masses persist after chemotherapy. It provides both therapeutic debulking and pathological assessment of residual tumor viability. Patients with refractory or recurrent TGCT may undergo high-dose chemotherapy followed by autologous stem cell rescue, or be enrolled in clinical trials exploring novel agents such as checkpoint inhibitors. Early referral to specialized centers improves outcomes. Prior to orchiectomy or chemotherapy, sperm banking is recommended for all men wishing future fertility. If bilateral orchiectomy is performed or hormonal function is compromised, testosterone replacement therapy restores libido, bone health, and quality of life. Standard follow-up includes physical examination, serum markers, and imaging every 3 to 6 months for the first 2 years. Then every 6 to 12 months up to 5 years, after which the schedule may be spaced further based on risk. Monthly testicular self-examination allows men to detect new lumps when they are still confined and highly curable. Educating patients to perform the exam correctly reduces diagnostic delay. Orchiopsy before age 2 relocates an undescended testis into the cooler scrotal environment, cutting the lifetime TGCT risk by roughly half, and preserving future fertility potential. Avoiding tobacco, maintaining a healthy weight, limiting exposure to known endocrine-disrupting chemicals may lower overall cancer risk, including TGCT, by reducing systemic inflammation and hormonal imbalance. Families with multiple TGCT cases benefit from genetic counseling. To discuss risk assessment, possible germline testing, tailored surveillance strategies for at-risk relatives. Overall 5-year survival exceeds 95% for stage 1 disease, drops to about 80% for stage 3, and falls below 50% for stage 4. Seminomas generally have better outcomes than aggressive non-seminomatous subtypes. Elevated serum markers, AFP, beta-HCG, LDH. Tumor size greater than 5 centimeters. Presence of nodal or distant metastases, each independently portend a poorer prognosis and guide risk-adapted therapy. Long-term survivors may develop secondary cancers, especially after abdominal radiation, and have an increased risk of cardiovascular disease due to chemotherapy-induced vascular injury, necessitating lifelong health monitoring. Comprehensive genomic profiling identifies actionable mutations and immune checkpoints in TGCT. Early phase trials of PD-1/PD-L1 inhibitors aim to exploit tumor immune interactions, offering hope for patients with refractory disease. Micro-RN, a 371A3P, outperforms traditional markers in sensitivity and specificity for TGCT detection, showing promise for earlier diagnosis. Monitoring treatment response. Detecting relapse via a simple blood draw. Recent studies tailor chemotherapy intensity based on IGCC-CG risk groups and early tumor marker decline, allowing de-escalation for good risk patients while preserving high cure rates and reducing toxicity. For prepubertal boys who cannot bank sperm, experimental testicular tissue cryopreservation offers a future avenue for restoring fertility through autologous grafting or in vitro spermatogenesis. Once techniques are validated, ongoing trials assess checkpoint blockade, CAR T cells, and vaccine strategies in TGCT, particularly for patients with relapsed or chemo-resistant disease, expanding the therapeutic arsenal beyond conventional chemotherapy. Liquid biopsies detecting circulating tumor DNA or microRNA in plasma could soon replace some imaging for surveillance, offering a minimally invasive method to track disease